Our next speaker is going to be Dr. Kheriaty. Dr. Kheriaty is the Director of Medical Student Education and Associate Director of Residency Training in the Department of Psychiatry at the University of California, Irvine. He is the founding director of UCI's Psychiatry and Spirituality Forum and serves as chairman of the Ethics Committee at UCI Medical Center. Dr. Kheriaty graduated magna cum laude from the University of Notre Dame in philosophy and pre-medical sciences and earned his MD degree from Georgetown University School of Medicine. He has published research articles and essays in psychiatric journals, as well as articles in bioethics, religion, and spirituality in interdisciplinary and theological journals. Dr. Kheriaty lectures frequently to professional and lay audiences in the areas of psychiatry, medical ethics, religion, and spirituality. Would you please join me in welcoming Dr. Kheriaty to the podium? Dr. Southern, if you would please join us as well. We have a presentation to give to you, Dr. Kheriaty. I'll let Dr. Southern do the honors.
In appreciation for your efforts, we have a scroll of commendation from the Los Angeles County Board of Supervisors for Dr. Kheriaty for integrating spirituality into psychotherapy in introduction. And this is in recognition of dedicated service to the affairs of the community and for the civic pride demonstrated by numerous contributions for the benefit of all of the citizens of Los Angeles County. Dr. Kheriaty, thank you.
Thank you. We'll take that. Thank you. Thank you for that kind introduction and for the unexpected award, which was a delightful and undeserved surprise. And I'm delighted to be here, mostly to be able to address you and just make a few remarks on this topic of spirituality and mental health, particularly in the work of psychotherapy. When I mention to people that I started a psychiatry and spirituality forum at a public research university, I immediately get one of two responses. Either I get a look of instant recognition, as if to say, yes, exploring these two things together makes perfect sense. Or I get a perplexed look, as though I just told the person that I plan to start an academic enterprise to explore the relationship between pretzels and moon rocks. And the perplexed responders, probably in the range of 40 to 50% of folks, wonder, well, what do these two things have to do one with the other? What does religion or spirituality have to do with the psychological sciences or the medical sciences? Well, I think a very elegant answer, at least a beginning of an answer, was given in an address that the late John Paul II gave to a gathering of psychiatrists. By its very nature, he said, by its very nature, your work often brings you to the threshold of human mystery. It involves sensitivity to the tangled workings of the human mind and heart, and openness to the ultimate concerns that give meaning to people's lives. He goes on to say that these areas are of utmost importance also to the church, and they call to mind the urgent need for a constructive dialogue between science and religion for the sake of shedding greater light on the mystery of humankind in its fullness. I think this nicely encapsulates perhaps one of the purposes of this conference, which is to begin a constructive dialogue between science, medicine, the helping professions, and various religious and spiritual traditions for the sake of shedding greater light on the mystery of humanity. And specifically, I think we're trying to shed light on the mystery of human suffering, suffering that so often takes the form of mental illness. Hopefully, we can also shed some light on our role as healers of those who suffer. Mental health professionals, as John Paul pointed out, attempt to delve into the tangled workings of the human mind and heart, and we assist those who are grappling with questions of meaning and purpose. Now, according to the original Greek roots of the term, the word psychiatrist, for example, literally means a doctor of the soul. But of course, in modern psychiatry and psychology, at least mainstream, this original meaning has largely been abandoned. The ancient Greek philosopher Plato claimed that the physicians of his day failed to cure diseases in ancient Greece because they separated the soul, the psyche, from the body, the soma. And I think the same complaint could probably be leveled against most contemporary psychiatrists and others in the mental health professional. We engineers of the synapse often focus exclusively on the body, or more specifically on the brain, to the exclusion of the soul. And there's a growing body of empirical literature from the past couple of years that suggests that patients and clients and consumers are not entirely happy with this current arrangement. A 1995 study of psychiatric patients showed that 80% of these patients considered themselves spiritual or religious, with 48% of patients designating themselves as deeply religious. Over half attended religious services and prayed daily. 83% believed that their spiritual beliefs had a positive impact on their lives, on balance. And this generally positive impact is borne out in other recent studies on spirituality and mental health. And I'll cite just one. This is a review article published in the American Journal of Psychiatry looking at all the studies that they could dig up over the past 10 years on religious commitment, spiritual practices, and mental health. The study found the following. Overall, on balance, 72% of the studies found a positive association between religious commitment and mental health. 16% found a negative association, and 12% were neutral. They found no association. So certainly we have to acknowledge the possibility for both benefit and harm here, but I think we could say that on balance, the evidence is tilting away from, say, Sigmund Freud's claim that religious belief is automatically or inherently neurotic or unhealthy. And I'll say more just in just a few minutes about Mr. Freud. What I think was most notable in this survey was the following finding. 38% of patients felt uncomfortable mentioning their spiritual or religious beliefs to their therapist. Now, therapy is supposed to be the place where all of the patient's thoughts and emotions and beliefs and life experiences can be openly expressed and discussed. And yet, a significant portion, a large portion of patients were uncomfortable in this therapeutic setting, mentioning something that they considered very important to their identity and to their life. Many of them, perhaps, this was the most important aspect of their lives. And to understand how we've come to this pass, to understand why this is the case for so many patients, I think a few words on the history of psychiatry and psychology in the 20th century are in order. So we're going to take just a couple of minutes and do a little historical detour. Bear with me, I think this has real present-day impact on the kinds of problems that we're trying to address here at this conference. So I want to consider for a couple of minutes the two major 20th century theories or movements in psychology. Psychoanalysis first, and then behaviorism in mid-century. Now, as we all know, the famous founder of psychoanalysis, probably the most famous psychiatrist in history, Sigmund Freud, was profoundly anti-religious. In fact, he argued that religious belief was not just mistaken, it was pathological. Believers were not simply wrong. According to Freud, they were sick. Religious faith was neurotic, in his phrase, the universal obsessive neurosis of mankind. Universal because it's so pervasive and we can't seem to get rid of it. Freud argued that despite outward appearances, the human person, human beings, are for the most part controlled by deterministic forces that are outside of our awareness. They're buried deep within our unconscious. He famously quipped that man is not even master of his own house. Freud called this theory a blow to self-love. But I think it was more than this. It was a blow to any sort of love, because love can only be given and received freely. And yet, human freedom was precisely what his theory of the unconscious tried to exclude. And Freud thought that among our unconscious wishes, over which we have no control, until we're psychoanalyzed perhaps, was the wish for an all-powerful father, which we project upon the external world. This father would protect us from the cruel realities of nature. You see, it's a dog-eat-dog Darwinian world out there, and we're alone, and life is basically meaningless. And we can't abide this truth, according to Dr. Freud. So we unconsciously project these religious or spiritual wishes for an all-powerful father who will care for us and right all wrongs in the afterlife, and so forth. Now, Freud thought that if we're sufficiently psychoanalyzed, if we're in treatment long enough, and these religious wishes are unmasked to be what they really are, that we'll just sort of relinquish them and give up these spiritual aspirations or religious longings and settle for more modest therapeutic and life goals. See, Freud didn't have any messianic pretensions. He did not think that psychoanalysis was a system in which people could find salvation. He stated flatly once that the goal of therapy was to turn neurotic misery into everyday unhappiness. Now this for Freud was the best that could be hoped for. Now it's interesting, he never admitted it publicly, but in a private letter he once confided to a friend that he envied religious believers, although he did not feel that he could follow them in their belief. Well, I will suggest later in this talk that a spiritually oriented psychotherapy will hope for and aim for more than everyday unhappiness. Human health and even flourishing, growth in freedom and responsibility, discerning and living according to one's particular vocation and calling, developing one's character strengths and virtues. All of these ought to be, I would suggest, ought to be among the goals of a spiritually oriented psychotherapy. And I think after hearing Dr. Souther's remarks this morning that these goals would be ones where there is significant overlap and lots of parallels with those that are espoused by the recovery model of illness. So, now, people realize that Freud's account of religious belief was clearly unscientific, okay, sort of armchair speculation rather than empirically based. And in mid-century, many people wanted to turn psychology into a more legitimate science. They wanted none of this mumbo-jumbo, whether religious or atheistic. And the next wave after psychoanalysis, it dominated the psychological sciences for many years, went under the banner of behaviorism. The behaviorists, I'm going to suggest to you, went off the rails just sort of in another direction. According to the behaviorists, an objective science of the mind must be restricted to externally observable things only. The only things that mattered are observable and measurable environmental inputs and behavioral outputs. Okay? So what went on in the subjective region of the mind was set aside. The mind functioned like a machine. It was completely determined by its environmental programming. And this is all that is needed to explain human psychology and human behavior. Now, as you might expect from this theory, the behaviorists waved goodbye to human reason and free will. And at least in its more extreme or ideological forms, behaviorism therefore became anti-spiritual. That we can know the truth about ourselves and about the world, that we can at least search for this truth, and choose to live according to what we discern in this regard. These are some basic premises, I would suggest, of all religious and spiritual traditions. But as I said, our rationality and our freedom were precisely those things that were denied not only by psychoanalysis, but then subsequently by behaviorism. It followed from this that human beings had no distinctive stature among the other animals. A dramatic example of this sort of thinking is the famous American behaviorist B.F. Skinner. He actually claimed that we could understand humanity completely by studying the behavior of rats and pigeons. Regarding human responsibility, his famous mantra was, "No praise, no blame." He wrote a best-selling manual on child rearing, which recommended that parents feed their children according to rigidly controlled schedules and give them a minimum of attention and affection. The title of his most famous book on human psychology is very telling: Beyond Freedom and Dignity. So there you have it. Now, this sort of nonsense could only continue for so long. The brain was smuggled back into psychology through advancements like MRIs and PET scans, and more refined techniques in psychology allowed us to begin experimentally to study things like human relationships and social interactions, and things began to look much more complex and much more interesting, I think, than the behaviorists dreamed. But human reason and free will, religious longings and spiritual aspirations, these things are still very much denied today by scientific popularizers and by the ideology of a sort of reductionistic biological psychiatry. According to this sort of ideology, all that we are, all that we think, and all that we do is completely determined by chemical discharges in the brain. Now, of course, proponents of these sorts of theories will appeal to your reason and your free will when they ask you to rationally consider and freely accept their arguments for this position. But okay, so much for history of psychiatry and psychology. As you can see from this brief history that I've sketched, the modern psychological sciences have, in one fashion or another, in recent years, often lost sight of the human soul. Is it any wonder, then, that patients with deeply held spiritual or religious beliefs are suspicious or skeptical of psychiatry or psychotherapists or mental health professionals in general? Is it any wonder that 38% feel uncomfortable discussing this important aspect of their lives with their therapist? I would suggest to you that we have a lot of work to do in terms of building bridges and overcoming historical prejudices. So with this historical baggage duly noted and hopefully understood a little bit, we can look ahead to the future and see how some of this anti-spiritual prejudice can be remedied. How can we better learn to appreciate and understand our patients' religious and spiritual convictions, even and especially when they differ from our own? Can these become an integral part of the psychotherapeutic process? I think that other questions follow naturally from these. What might a spiritually oriented psychotherapy involve concretely in a day-to-day practice? What distinguishes such an approach from ministry or spiritual direction? And as was suggested earlier, it's very, very important for us to make this distinction and to understand how these roles can be complementary and not confused. Is there a danger of confusing roles here? I think there is. There's a danger of perhaps going beyond one's area of expertise, both on the part of the therapist and on the part of perhaps the spiritual director. And I'd like to begin exploring these questions with some considerations on the concept of vocation. I think the idea of a vocation has application in the clinical setting in two ways. First, we could talk about the vocation of the therapist, and second, the vocation of the patient. The Latin root of the word vocation, vocare, is where we get the word vocalize. Literally means to call. So a vocation is a calling. In monotheistic religious traditions, the caller is God, and the one called, the one who responds, is the human person. Non-theistic traditions and systems very often will have concepts that are, in many respects, analogous to the concept of vocation. So I think this has wide applicability across traditions and worldviews. An element common to many spiritual and religious traditions is the notion that each of us has a specific purpose for which we are here. And if we live according to this calling, we are more likely to find happiness and fulfillment. And if this calling is thwarted, or if the vocation is ignored, then the person is subject to suffering and to discontent and other maladies. So in exploring this concept of vocation, I'll start with a few remarks about the vocation of the therapist. if we understand therapy as a vocation and understand ourselves as having been called to this form of work, I believe that it could have profound effects in terms of changing our entire approach to therapy and to dealing with consumers and clients. Thank you. First of all, whenever a new patient or client walks into our office, we'll see this as not some random happenstance, but as a manifestation of providence. In other words, it's no accident that I am treating this person here and now. I, as an individual who has been called, and not just one more member among others of this profession. I have something unique to offer this person. It's no accident that both of us are here. I think this sense of our own vocation leads to a greater sense of our responsibility, not just to the individual or to society, but perhaps also to God or a higher power. The concept of vocation may imply that we have to give an account of how we have used the professional talents and gifts that have been given to us. Now, the specifics of how we understand our vocation and our responsibility will depend on our particular worldview, of course. But at the very least, I think we can consider ruling out the possibility that for this patient we're interchangeable with anyone else out there. Okay, a couple of considerations about the patient's vocation in the context of treatment and recovery. I would suggest that often a significant role for the therapist is to help the patient with what we could call vocational discernment. Now, in saying this, I'm not claiming that the therapist has some sort of privileged knowledge or insight into what the patient's life calling might be. Okay, we're not omniscient. On the contrary, the patient's calling can only be something that the patient discerns and accepts with full freedom and responsibility. But therapy can begin with the premise that the patient does indeed have a purpose. Perhaps in spite of outward appearances, their life has meaning. The meaning and purpose can be found despite whatever it is they're suffering, and perhaps, paradoxically, in and through what they're suffering. So to use a metaphor that Socrates would employ, our role is not to give birth to the patient's vocation. Our role is to act as a midwife to facilitate this birth. Should I marry this person? Should I accept this job? Is God calling me to ministry or some other work? These and questions like them are ones that often come up in the consulting room. Now, we can't answer such questions for our patients. However, with our intimate knowledge of the patient's personality, of their strengths and their vulnerabilities, of their temperament, we can help to guide them through the process of discernment, through the process of self-knowledge, so that they can begin to see their vocational path more clearly. So in the course of good psychotherapy, the answers to some of these questions may be revealed to the patient. And observing the patient as she comes to see and then freely accept her vocation can be, at least in my own experience, has been tremendously rewarding in my work as a therapist. Now, you heard yesterday a bit about the work of Viktor Frankl, and I was going to mention him in this context, but I'll skim over my remarks on Frankl in the interest of time and just commend to you not only his book Man's Search for Meaning, which is his most famous work about his days in surviving Auschwitz, but his other less well-known work, but I think equally valuable, the book The Doctor and the Soul, can be very helpful. I want to turn now and discuss briefly some of the common difficulties that we can encounter when dealing with religion or spirituality in the clinical context. Because of the antagonism that the history of psychiatry has generated toward religion, religious believers have often responded with suspicion towards concepts of mental pathology and treatment. This can, of course, lead to difficulties in the clinic. Patients may reject the idea of having a mental illness, and even if they do accept this, they may be reluctant to accept treatment with psychotherapy or medications or other things that could prove potentially helpful. I think all of us have experienced difficulties in this regard. And very often the patients will cite their religious beliefs as reasons for refusing a diagnosis or refusing treatment recommendations or refusing to engage in recovery. Many religious believers suspect that psychiatry or psychology are encroaching upon areas of life that were once occupied by religion and spirituality. People have commented to me, for example, that it seems like people now turn to therapists where once they turned to priests or rabbis or pastors. Now, I think everyone in this room understands that mental illness is real and that it causes real and profound suffering for many people. Something like depression or schizophrenia is not the result of a moral or spiritual fault or failure on the part of the person who's suffering. How can we better communicate this to patients who may be struggling with these afflictions and who may have heard or come to believe otherwise? And just to cite one example, I would say that I see this frequently in my clinical work with Christian patients. If I would just pray more or have more faith, then I wouldn't be suffering from anxiety or depression or whatever. And I often remind them that Jesus himself suffered anxiety in the Garden of Gethsemane. I think that drawing on the patient's own religious tradition can be helpful in overcoming some of these false prejudices. So, for a Jew or a Christian, I often cite the book of Job as an example. All of Job's friends insisted that he must be suffering because of something that he did wrong. God finally intervenes to correct not Job, but his friends who thought they were so enlightened. God says that he allowed Job to suffer precisely because Job was a just man. So imputing his afflictions to him as a moral fault, though it might have appeared reasonable on the surface to his friends, turned out to be false. The New Testament contains a story that I've used with Christian patients in this context as well. In John's Gospel, the disciples approached Jesus and asked why a certain man was born blind. Was it his sin, they asked Jesus, was it his sin or his parents that caused him to be born blind? And you see the assumption implicit in the question, don't you? The disease must have been due to some specific moral fault, either this man's or his parents'. But Jesus corrects them. You're barking up the wrong tree here. You're posing the wrong question. He says that it's neither the blind man's fault nor his parents'. And I'll point out to my patients that Jesus does not answer their question, at least not directly. The cause of the man's suffering remains a mystery, as does the cause of so much of our own suffering. But Jesus does hint that God can use this suffering to bring about a greater good. In this case, it turns out to be the man's cure. Suffering, I think, remains a mystery. But one thing that we can know, and I think that we can say and try to communicate to patients and to religious communities is this. Just because we are suffering, we shouldn't automatically conclude that this is due to our own personal fault or failure. There can be a tendency among pious people to collapse the distinction between things that are happening on the natural level and things that are happening on the spiritual level. We can, many patients can presume upon a miraculous cure when perhaps a medical cure is available. I think we need to make these sorts of interventions in an intellectually honest way. And this requires a bit of depth and understanding of various religious and spiritual traditions. It's not to say that all practitioners have to become theologians, but we shouldn't quote the Bible or the Quran in a sort of cavalier or half-baked manner. Working with a patient's religious or spiritual beliefs does not require that we share their convictions. And it does not involve imposing our own convictions on the patient. We have to be delicate and sensitive in this regard. It can sometimes be a matter simply of drawing on something that they already claim to believe or want to believe and using that in order to help them. I characterize my approach as a both-and rather than an either-or approach. So my answer to the question of whether I should take medications or pray more to recover from my depression is yes. In this way, the person's faith is validated, or at least it's recognized and respected in the clinical setting. And I think we can avoid false dichotomies that either this is a psychological or a medical or a biological or a spiritual problem, and recognize that it may involve all of these dimensions. I want to turn for just a couple of minutes to the topic of spirituality and suicide prevention. Ever since a close friend of mine from high school took his own life, I've had an abiding personal and professional interest in the problem of suicide. Mark Twain quipped that man is the only animal that blushes, or needs to. Henry George, a 19th century economist, said that man is the only animal whose desires increase as they are fed, the only animal that is never satisfied. Perhaps related to this human characteristic is another unique feature of human beings. Man is the only animal that sometimes chooses to take his own life, contrary to popular myths about lemmings. I want to speak a bit about this problem of suicide because I think that this is an area where the behavioral sciences and religious and spiritual traditions have often proven helpful. Research findings consistently show that religious faith and spiritual practices do in fact lower the risk of suicide. I think that we should always pay close clinical attention to the patient's religion and spirituality, but I think it's particularly important when it comes to doing a suicide risk assessment. The work of one of the founding fathers of modern sociology, Emil Durkheim, that was done 100 years ago, is still relevant here. He wrote a book called Suicide, in which he showed that suicide rates were a measure of social disintegration. This is, I think, the flip side of the Roseto, Pennsylvania phenomenon that was discussed earlier. In a related vein, he found that suicide rates were higher among those countries which tended to be less religious. And these findings have been replicated many times since, both in large epidemiological studies and in smaller studies of mentally ill populations. And the consistent consensus is that religious beliefs and spiritual practices are, in general, somewhat protective against suicidal behaviors. And it seems, or the data suggests, that the protective role for religion and spirituality is likely threefold. First, religious communities, in non-specific ways, in ways that could be replicated by non-religious communities, help believers through social networks, through fostering social cohesion and solidarity, friendships, and so forth. Second, the moral teachings of most religions, including all of the major world religions, prohibit taking one's own life. And finally, religious beliefs, as was suggested earlier today and yesterday, can help provide a sense of meaning, purpose, and hope that helps someone to get through a suicidal period in their life. Anyone here know what the #1 suicide spot in the world is? Golden Gate Bridge in our sister city to the north. The city finally voted to put up a suicide barrier. Over 1,400 people have died jumping from the bridge. This is about approximately 1 every 2 weeks, which is rather astonishing. One of the casualties at the bridge was a depressed man in his 30s. And after his death, his psychiatrist accompanied the medical examiner to the man's apartment, where they found his diary. His last entry in the diary, written just hours before his death, read, "I'm going to walk to the bridge. If one person smiles at me along the way, I will not jump." We do not know all that we can be to another person. We are relational by nature. We are made to flourish in communities of love and mutual support. The psychological sciences are only beginning to more fully recognize and appreciate this basic fact of human life. but this is a basic fact of human life that has been long known, understood, and explored by religious and spiritual traditions. So not only do they have something to learn from us about mental illness, we have a lot to learn from them about healing. So healthy religious communities can provide their members protection from some of the social disintegration and alienation and loneliness that Emil Durkheim described in his studies and that we see in this case example of the man who jumped from the bridge. Religious belief can be protective against suicide for another reason that I've mentioned, and that's that a religion's moral teachings may deter many who would otherwise consider this to be a viable option. One of my patients, for example, is a young man who suffers anxiety and depression. He told me at one point, told me point blank, I don't believe in God, so I don't see anything wrong with suicide. And he was planning to kill himself if he couldn't work out his financial difficulties. You can contrast this with one of my other patients, a young man who struggles with depression and sexual problems. He admitted, I would probably have killed myself already, but I'm terrified of going to hell. Now, many people might consider the fear of eternal punishment some sort of repressive or unhealthy fear, but at least in this case, that particular belief got this fellow through his suicidal period, and I'm happy to report that he's now doing quite well. The third protective factor, which has been discussed at some length already, is the virtue of hope. Religious faith can, and very often does, offer hope in situations that can outwardly appear hopeless. A famous psychiatrist, Aaron Beck, who's well known for developing cognitive therapy for depression, did one of the only long-term prospective studies of suicide. He followed 800 patients who had been hospitalized for suicide attempts or suicidal thinking, and he monitored them for the next 10 years to find out which of them ended up dying by suicide. And he looked at all kinds of things to try to tease out risk factors. He looked at the patient's diagnosis, at the number and type of mental and physical symptoms, whether or not they had other medical conditions, whether or not they were in chronic pain. He looked at social and economic factors, and so on. The one factor that stood out above all the others, the one factor that was most predictive of suicide, was not how sick the person was, or how many diagnoses they carried, or how many symptoms they exhibited, or how severe their illness happened to be. The most dangerous factor was hopelessness. The person who believed that her situation or his situation was utterly without hope is the most likely candidate for suicide. And as we all know, there is no prescription or medical procedure for instilling hope. Mental health professionals have much to learn about this very important virtue from, I would suggest, spiritual and religious traditions. One of my patients, a woman who suffered sexual and physical abuse at the hands of both of her parents, told me, if it were not for my relationship with Jesus, I would have killed myself a long time ago. I have no doubt whatsoever that this claim is true. Now, Aaron Beck's findings in regard to the virtue of hope and suicide prevention brings me to the next topic that I'd just like to touch on, and that is the role of character strengths and virtues in mental health. And this is an area, again, of considerable overlap between the modern psychological sciences and various religious, philosophical, and spiritual traditions. Many traditions have placed emphasis on the importance of acquiring a core set of virtues and character strengths that are necessary for happiness, for health, and for human flourishing. The examples that I could cite are many. I'll mention in the Eastern traditions, certainly Confucianism and Buddhism place great emphasis on the virtues. Most definitely the Judeo-Christian tradition in the West. And even non-religious philosophical traditions have paid a lot of attention to this important area. I'll mention the ancient Greek philosopher Aristotle and his teacher Plato thought that we can only attain happiness by living in accordance with the virtues, by becoming a certain sort of person. And their list of virtues, or character strengths, that they thought was most important is interesting. The Greek philosophers tried to distill all the major virtues under four main ones that they called the cardinal virtues. The first one was what we often translate as prudence, but it's more accurately translated as wisdom or practical wisdom, right? Applying wisdom to everyday situations in life in order to make decisions, helping us to choose what is good or what is best for us and for others. The second one was justice, which is the virtue by which we give other people what is due to them or what is owed to them. Temperance, through which we can learn to regulate and control our appetites for food and drink and sex and so forth. And finally, courage or fortitude, the virtue that helps us to overcome difficulties, to face suffering and persevere. And in the East, Confucius developed a list of virtues that is remarkably similar to this one. In the West, later theologians like Augustine and Thomas Aquinas developed this idea of the virtues and added a few more from the Christian tradition, namely the three supernatural virtues of faith, hope, and love. Now, a few years ago, the former president of the American Psychological Association, famous researcher by the name of Martin Seligman, he's known for his theory of learned helplessness, started a new, I guess you could call it a movement, that now goes under the name of positive psychology. Seligman decided, in a conversation with his young daughter, I think she was 8 years old at the time, when she enlightened him on this score, he decided that psychologists and psychiatrists had for too long focused only on mental disease, on disorder, on pathology, only on what could potentially go wrong, and not on what could go right in terms of human mind and psychological development. We learned a lot, no doubt, by looking at people's weaknesses and vulnerabilities. But Seligman argued that it was time to begin studying in a rigorous, scientific way those positive traits and habits that led to human happiness, health, and flourishing. And the results of many, many studies are summarized in his book, Character, Strengths, and Virtues, which I recommend as a reference. Now, the positive psychology researchers distilled the traits that led to mental health and flourishing down to 6. These were, listen carefully, wisdom, justice, temperance, courage, love, and what they labeled transcendence, which is analogous, you could say, to faith and hope. Now, if these 6 virtues sound familiar, it's because what these researchers discovered, and this wasn't their purpose, they weren't setting out to reinvent the Confucian or the Western Judeo-Christian traditions on this score, but and it took some time to realize that they had done precisely that, but in fact, good science had confirmed from a different perspective and using different methods of inquiry what had already been discovered by a long and laborious and refined tradition of philosophical and theological reflection. So I mentioned the positive psychology movement because I think it's an important contemporary area of convergence between modern science and various faith traditions. And if you'll excuse the pun, it represents a very positive development in mental health care because it allows us to focus not only on pathology, on illness, and on disease, on what a patient has, but also to cultivate the patient's own internal resources, what the patient is, or who the patient could become in order to help them overcome their difficulties and deficits. And clearly, I would say also that this has many, this would hopefully resonate with many of the ideas that are espoused by the recovery model of mental health. Positive psychology suggests that mental health is not merely something negative, not merely the absence of disease or pathology, but something positive. It requires growth and development. It requires taking what is good in us and trying to help it to become better or stronger. And finally, in this context of talking about the virtues, I'm going to spend the last couple of minutes of my talk taking a look at one increasingly important virtue that's been studied in recent years in relation to psychotherapy and recovery, and that's the virtue of forgiveness. beginning with the seminal research of Worthington and Bob Enright at University of Wisconsin. The role of forgiveness in psychotherapy is receiving increasing research attention and now clinical attention. And I only have time to touch very briefly on this topic. If you're interested in more information, I would recommend the book Helping Clients Forgive that was written by Rick Fitzgibbons, a friend of mine, and Bob Enright, who's the researcher. Fitzgibbons is the clinician author. It's published by the American Psychological Association Press. So this virtue is becoming mainstream in psychology. Now, of course, the process of forgiveness can be understood, appreciated, and cultivated without reference to spirituality. And very often, I think this is done. However, it's important to recognize, and this certainly has been the case in my own clinical experience and personal experience, that forgiveness is often tremendously assisted and developed if we can draw upon the patient's own spiritual resources in the process of trying to help them forgive those who have genuinely hurt or harmed them. Now, many religious and spiritual traditions see forgiveness as a positive virtue, and in some traditions, the commandment to forgive others is absolutely central to the spiritual life. From the perspective of mental health, forgiveness has been shown in hundreds of studies to be helpful in overcoming anger, in healing from trauma of various kinds, including perhaps trauma inflicted by mental health professionals, and recovering from depression. So we see here that what makes sense spiritually also makes sense psychologically. As anyone who has ever been genuinely hurt or harmed knows very well, true and authentic forgiveness for a genuine wrong done is one of the most difficult things that a human being can achieve. In light of this, any assistance from the person's religious or spiritual tradition can be helpful in facilitating what is typically a long and laborious and most often emotionally painful process. Well, time allows us only to scratch the surface here on any of these topics. Much more could be said on this and on other things. I'll mention just one area that I think needs more research and more clinical attention, and it was touched upon in the remarks in the first keynote address this morning, and that's the relationship between a person's early attachment history and their later spiritual development. I've worked with many patients for whom this becomes an issue in the clinical setting. Poor early attachments can hinder a person's later spiritual development. So I think that these and other themes like them can be explored later this afternoon in the breakout sessions and in hopefully subsequent conferences of this nature. So in concluding, I want to commend and thank the Los Angeles County Department of Mental Health and the California Institute of Mental Health for their courage and their willingness to host this conference, to take a look at these issues, to begin an exploration and a conversation and a dialogue among people that historically, at least in the last 100 years, haven't been talking to one another. I have no doubt that your efforts in this regard will bear fruit in your own life and, most importantly, in the lives of our clients and patients. So I hope that my brief remarks this morning have shed some light on the historical challenges that lie behind us, the current problems that we're facing today, but also the possibilities that are ahead of us if we can move forward thoughtfully, carefully, and honestly in exploring mental health and spirituality. So I want to thank you for your attention, and God bless you in your work.